In 2015, governments made an ambitious commitment under the Sustainable Development Goals to end the AIDS pandemic. While remarkable progress has been made towards achieving these goals, we are still off track to meeting this target. New infections remain too high, while stigma, discrimination, and violence threaten the progress that has been made. As activists, we need to step up all effort to hold our governments accountable for the commitments they made. To do this, we must listen to the voices of those most affected. It is important that we understand that there are structural barriers that hamper the HIV response, especially when it comes to marginalized communities. These structural barriers not only make it harder to reach the global targets that have been set, but would not make progress sustainable. In the fight against HIV and the well-being and health of all, everybody counts. What are the global HIV targets? July 2015. 17 Sustainable Development Goals were set by the United Nations, each with specific targets to be achieved by 2030. SDG 3 aspires to ensure health and well-being for all. It includes a bold commitment to end particular epidemics, including AIDS, tuberculosis, and malaria. 2016. A high-level meeting was convened by the United Nations General Assembly where a declaration was taken that included region-specific targets for Eastern and Southern Africa. It also included a commitment to put a quarter of all HIV resources towards HIV prevention and ensure that at least 6% of the response would be community-led. Significantly, there was a commitment towards ensuring access to justice and addressing legal and policy barriers towards HIV prevention. Region-specific targets have also been set, among others, through the African Union Catalytic Framework. October 2017, the Global HIV Prevention Coalition was launched. This coalition brings together multiple stakeholders from governments, UN agencies, and civil society. The coalition's goal is to work together towards the 2030 target. December 2017. Ministers of Health from the SADC region endorsed a framework for HIV prevention based on the HIV prevention targets. Ending AIDS as a public health threat. What does that mean? Throughout history, epidemics of infectious diseases have a lifespan. They rise over a period of time, they peak, and then they start to decline. Ending AIDS as a public health threat is not quite the same thing as ending AIDS completely. UNAIDS has determined that when the number of people newly infected with HIV globally has declined to less than 200,000 per year, this will mean that the HIV epidemic is under control. In order to reach the ambitious 2030 targets, new HIV infections and AIDS-related deaths need to be reduced by 90% by 2030, compared to 2010. Furthermore, in order to achieve these targets by 2030, 95% of people living with HIV globally should have been tested and know their status. 95% of those who are HIV positive should be on treatment, and 95% of those on treatment should be virally suppressed. For progress to end AIDS as a public health threat to be sustainable, structural barriers to HIV prevention need to be addressed. Eliminating HIV-related stigma is part of this. However, structural barriers go further than this. Structural barriers to HIV prevention are social, legal, and policy barriers that prevent people, especially those who are already marginalized, from accessing HIV prevention services. Central to all of these is fighting HIV stigma. HIV prevention is off track. There has been remarkable progress towards some 2030 targets across the globe. The scale-up of antiretroviral therapy and preventing mother-to-child transmission of HIV are examples where significant progress has been made. HIV prevention, however, is not doing so well. The fast-track goal was reducing new infections to under 500,000 per year by the year 2020. This figure represents a 75% reduction from the number of new infections which occurred in 2010. By 2019, new infections had only declined by an estimated 23% since 2010, meaning that we are way off the 75% target. Even though East and Southern Africa, where 54% of people living with HIV reside, is doing better than any other region in the world, with a 38% reduction in new infections between 2010 and 2018. The sustainability of this progress means that stronger focus on stigma, discrimination, and the gender dynamics of the epidemic are needed. In 2019, of every 5 new infections, 3 were among women, and the incidence of HIV infections among adolescent girls and young women aged 15 to 24 years remains inordinately high. They are 2.5 times more likely than their male peers to acquire HIV infection. Patriarchal gender norms limit the agency and voice of women and girls. Multiple studies show an association between lower relationship power and a lack of condom use, or a more inconsistent condom use. Gendered power dynamics within intimate relationships constrain women's sexual and reproductive rights and limit their decision-making power, including their ability to refuse unwanted sex, negotiate safer sex, and mitigate HIV risk. Knowledge about sexual and reproductive health and the prevention of HIV among adolescent girls and young women remains low. A quarter of new infections in East and Southern Africa are among key populations and their sexual partners. This is often due to laws and policies that criminalize key populations and the consistent stigma and discrimination that they face in society. LGBTI persons and marginalized women, such as sex workers or women who use drugs, often fear judgment, violence, or arrest. As a result, they struggle to access sexual and reproductive health services, including HIV prevention services. Multiple intersecting forms of gender-based violence are experienced by transgender people. Drug use or consumption and/or the possession of drugs for personal use is specified as a criminal offense in many countries in the region. These laws and policies force people who use drugs away from public health services. Where do we move from here? We must step up HIV prevention and especially take seriously the need to address structural barriers to HIV prevention. In particular, respect for, protection, and promotion of the right to bodily autonomy and integrity should be at the core of our efforts to address structural barriers. Combination prevention approaches should include all 3 aspects: biomedical interventions, behavioral change, and addressing structural barriers. However, it has been clear that there has been an overemphasis on biomedical interventions and behavioral change, while too little progress has been made in addressing structural barriers. A comprehensive approach is required, including combination prevention programs that take account of gender inequalities, improving girls' access to secondary education, and increasing access to sexual and reproductive health services. There is an urgent need for conducive laws and policies and for programs that serve the needs of marginalized populations. For example, decriminalizing sex work could avert an estimated 33 to 46% of new HIV infections globally over 10 years. Working towards ending the global threat of HIV and AIDS is a shared responsibility for governments, civil society, communities, donors, multilateral institutions such as the United Nations, regional bodies, and other stakeholders. Global goals and targets provide a framework within which the diverse partners can coordinate their efforts to end the HIV pandemic. Let's all do our part to ensure that no one is left behind, because everybody counts.